Good afternoon, everyone. So today we would like to present for case 36, 2019, a 34-year-old man with dyspnea, odynophagia, and abdominal pain by Nora Takumi. So course director is Dr. Pacheco. Today's date is April 7th, 2021. So next, please. So sorry. Outline is a chief complaint and onset, medical history, family social history, physical exam, labs, diagnostic process, pathology, treatment. Next, please. Please post here your question. Chief complaint and onset, a 34-year-old man with asthma was transferred to this hospital in the winter because of dyspnea. So onset is this symptom began a month ago. So medical history, he has a history of depression, anxiety, and asthma. He has no known allergies. 13 years ago, he was treated for chlamydia and gonorrhea. His medication included inhaled albuterol, inhaled budenoside formoterol, and oral alprazolam as needed. So 3 months ago, odynophagia developed and he had presented with white plaques. Diagnosis of candidiasis was made and he was treated with an oral suspension of mescaline. 2 months ago, he had lost 13.6 kilograms. He had nausea and intermittent vomiting and mild diffuse abdominal pain. 1 month ago, he developed exertion dyspnea and cough. Cough intermittently produced dark grayish sputum. Sometimes it contained a small amount of blood. He used an albuterol inhaler, but the dyspnea one only wasn't. Next, please. So medical history. So 2 weeks before admission, he developed fatigue and myalgitis, night sweat, shaking chills, and mid-sternal chest pain. And 3 days before, he had noted fever. On the morning of admission, he had progressive dyspnea and odynophagia and was presented to the emergency department of another hospital for evaluation. So family history and social history. A 34-year-old man with Mediterranean descent born in southeastern United States. He had traveled to Northern Africa in the remote past. He has unstable housing and slept in shelters or at the homes of friends and family in coastal New England. So he had smoked 10 cigarettes per day since he was 18 years, drinking 2 glasses of wine every evening and smokes marijuana occasionally, no illicit drug use. He had had 20 previous sexual partners, both men and women, and has used condoms inconsistently. Next, please. So physical exam, temperature is 38.7, pulse 121 beat per minute. I think normal is 70. So blood pressure is 96/65, kind of low. Respiratory rate is 20 breaths per minute, normal. So oxygen saturation is 95. I think average about 99. So the weight is 99 kilograms. The height is 170. BMI is 70.3, is low. The patient was sick and appeared chronically ill. His mucous membrane was dry and had white plaque. His lungs were clear with no plaque, lunocoid, and wheezes. Physical examination of the skin revealed diffuse steroids, scattered hypopigmented maculas on the arms and biolacteous plaque with irregular boards on the front aspect of the medical right foot. The remainder of the examination was unchanged.
Okay,
So
so
I continue.
yeah, so I'm going to continue with labs. Um, from these labs, I think the most important thing to remember here is that he had anemia. There was presentation with anemia. Also, he had low lymphocytes, as you can see here, and he also had low CD4 T cell count. Also, he had antibody differentiation. Wait, hold on. Oh.
I just don't worry. There's some kind of echo going on, but I don't know first. Maybe you have two devices at the same time, or maybe in your room broadcasting.
Is it okay now?
Yes, yes, yes.
Oh, okay, okay. So yes, okay. So you can see he has anemia first. I think that's one of the important key points. Also, he has low CD4 count. He antibody differentiation assay also confirmed diagnosis of HIV-1 infection, and the viral load was 363,000 copies per milliliters. He also has 1,3 beta D glucan levels that's over 500, which is high, and sputum smear was negative for acid-fast bacilli, which is Mycobacterium tuberculosis, and VDRL test was also negative. A radiograph was done because he had dyspnea, and the radiograph showed, the arrows here show opacities on the lungs, and the CT also showed more opacities, but the arrows here points to the spared normal lung tissue that was also found, but there were no presence of any mediastinal lymphadenopathy or pleural effusion. An endoscopy and biopsy was performed, and here you can see this is the endoscopy of the stomach, and you can see some hyperemic nodules here. Although here in the duodenum you can also find the lesions, although it is less prominent than in the stomach. This is H&E staining of the biopsy taken from the nodules. So here you'd find spindle proliferation, and you also have the arrows here point to some hyaline globules, and you also find the same thing in the duodenum, but like before, it is also less prominent than here. And this is immunohistochemical staining again of the spindles. Here, this is staining for ERG, which is a specific marker for endothelial cells, and it was found here positive, as you can see. And also staining for HHV8, which is human herpes virus, was also found to be positive, as you can see on this panel. The last important lab results that was gotten was biopsy of the skin lesion, biopsy specimen of the skin lesion. Here on panel A is just a photograph of what the lesions looked like, but here is the H&E staining of the biopsy, and this is just a magnified view of this one, and it shows some vascular spaces, and these vascular spaces are lined by hyperchromatic hobnailed cells. And here, immunohistochemical staining also shows that it's positive for human herpes virus, like the last time. So I'll walk you guys through the diagnostic process. This case was evidence of an advanced HIV infection, and this was determined because obviously he had some previous opportunistic infections. Like Takumi said, he had the Candida esophagitis 3 months ago, and now he's presenting with pneumonia, abdominal pain, and hematemesis. Although there are many possible causal agents to these symptoms, it was narrowed down to pneumocystis jirovecii, which is a fungal infection, and this was due to the elevated 1,3-beta-D glucan levels, which is specific for pneumocystis jirovecii. Another key point, like based on the labs and physical exam, is the purple skin lesion with irregular borders that was found on the plantar aspect of the medial right foot. And this narrowed it down to two possible diagnoses. It was either bacillary angiomatosis or Kaposi's sarcoma. And I'll explain on the next slide how the diagnosis was made. But I think we need to also understand that there are some certain epidemiologic factors that were also considered in this diagnosis. First one was that he traveled to Northern Africa, and because of this, they thought maybe it could be Leishmania infection. And this is because many people in Northern Africa who have HIV, who are infected with HIV, are very susceptible to contracting this particular infection. But the reason why this was ruled out was because he didn't have any Kala-Azar reaction. He also did not have any hepatosplenomegaly, and he didn't have any fever. His birthplace in southwestern United States was also considered because people who are infected with HIV that were born here are very susceptible to, or who live here are very susceptible to contracting coccidioides immitis. And the reason why this again was ruled out, although it's very similar to pneumocystis jirovecii, but it was ruled out because he didn't have any bone diseases or any meningitis. So that ruled out this particular infection. And the last epidemiologic factor was his unstable housing, which would make him susceptible to Rickettsia prowazekii infection. But the reason why this was also ruled out was because this particular infection presents with rashes, and the rashes are like skin eruptive, and he didn't have any of that. So that was why all of these infections were ruled out. Then the differences between Kaposi's sarcoma and Bartonella infection, and why Kaposi's sarcoma was determined to be the diagnosis. In Bartonella infection, it is usually accompanied by fever, but there was no fever in this patient. Also, the presence of the skin lesion with irregular borders that were present on the sole of the feet, the visceral lesions in the mouth and the gut was also pointing towards Kaposi's sarcoma, because Bartonella infection, it will rarely present with lesions in the palms or sole or in the mouth. Also, in Bartonella infection, there's usually presentation of peliosis hepatitis, but there was no symptom of that in this patient. So that was why Kaposi's sarcoma was the confirmed diagnosis. Here is just a gross appearance of what the lesions look like, although this is not from this patient, but this is just a visual representation to let you guys know what it looks like. So you can see the disseminated lesions. Also with Kaposi's sarcoma, you find proliferation of abnormal vascular endothelial cells. And like we said before, the lesions were positive for HHV8. And that's very predictive of Kaposi's sarcoma in HIV infected individuals. Histology would also show large endothelial cells of capillaries that protrude into the lumen like buds, lesions with proliferation of capillaries, and fibrosarcoma-like tissue in varying proportions. And in late lesions, as seen with this particular patient, there was spindle cell proliferation with sarcoma-like properties. For the treatment chosen was combination antiretroviral therapy, and this was chosen because this is the underlying cause of the Kaposi's sarcoma. Although the physicians were actually quite skeptical, and they suggested a chemotherapy regimen, and this was because he is a very high risk. He has many high risk factors such as very low CD4 counts. He had visceral involvement of Kaposi's sarcoma, and he also has a history of many other opportunistic infections. But at the end of the day, the patient opted for antiretroviral therapy only, just based on his own preferences, and he was more comfortable with that. He was treated with vancomycin, cefepime, and fluconazole and prednisone for pneumocystis jirovecii pneumonia. And although the follow-up was inconsistent for a while, after about 7 weeks, the CD4 count began to increase, and the viral load had declined to 269 copies per milliliter. So in summary, we had a 34-year-old man with a history of asthma that was presented to the emergency room with progressive dyspnea and odynophagia. He had a history of candidiasis, and labs showed he was positive for HIV-1 infection. He was diagnosed with pneumocystis jirovecii pneumonia. Endoscopy revealed nodules in the stomach, and biopsy revealed spindle cell proliferation. He also presented with skin lesions on his right foot. These suggested Kaposi's sarcoma. All of these symptoms had occurred as a result of an advanced HIV infection, and he was treated with antifungals for the pneumonia and antiretroviral drug. Here's our reference, and we'll take any question now.
Thank you very much. Can you please take the first slide of the presentation? All right. Okay, so my first question is, this patient has Kaposi's sarcoma. From reading this case, and this is question to Takumi. From reading this case, what is, from your opinion, the most important diagnostic marker for confirmation of diagnosis in this patient?
Excuse me, I cannot hear you, very noisy.
Got it. So, Nora, would you be so kind to mute your microphone?
Okay.
All right, Takumi, I hope you can hear me better right now.
Yeah.
So my question is, when you read this article, so
Yes.
what in this article was, from your point of view, pointing to the diagnosis of Kaposi's sarcoma, that was most reliable kind of marker of Kaposi's sarcoma?
You mean HIV?
I mean, in this patient. So,
Abdominal pain, I think. Abdominal pain.
Abdominal pain is very non-specific sign of any kind of disease. I'm saying, let's say, what kind of study in this, what kind of diagnostical examination, or let's say laboratory examination, pointed to correct diagnosis? Or you think it's combination of several? So what do you think? How how doctors were able to diagnose that this patient has Kaposi's sarcoma?
So HHV immunohistochemical stains.
HIV.
HVH.
Okay, so HH8. Okay, so this was from your side, from your point of view, of the most important diagnostical test. Very good, very good. Nora, do you think, do you have the same opinion, or you have different opinion on this?
I agree. HH8 is quite specific, yeah.
Very good. So, and my second question is coming from the groups. So the Samantha Innocente wrote, what are the symptoms of pilosis hepatis? As far as I understand, the patient had pilosis hepatis.
Like, like liver disease and jaundice, hepatomegaly, and liver failure.
Mm-hmm. Anything else to add to this answer, Nora?
Sorry.
Nora, you're muted. Is anything else to add to this question?
Blood-filled lesion.
Blood-filled lesions in the liver.
Mm-hmm. Very good. Very good. Now, second question coming from group number 3. Why do you think it took so long for CD4 count to increase? So question to Nora.
I think it took a while because, like I said before, the physicians were skeptical about using ART alone, antiretroviral drugs alone, because they felt like using chemotherapy would have been more effective. So I feel like if they had followed chemotherapy, it would have regressed faster. But like I said before, the patient was more comfortable with antiretroviral drugs and didn't want to follow that chemotherapy regimen.
Right, thank you very much. One more question is coming here from group number 5. Is why does this patient have no? What will the biopsy of Kaposi sarcoma show?
The biopsy of Kaposi sarcoma.
Yeah. So can you describe what biopsy of Kaposi sarcoma usually presented with?
So we can see here, like I explained before, the spindle cell proliferation one. Also, it had occasional hyaline globules, and it's shown here by the arrows. You also have proliferation in the lamina propria. Yeah.
So, and there's signs which were shown here of Kaposi sarcoma. Are they classical, or it's something different from what usually tested in step 1?
Sorry, can you ask the question again?
So the question is, what you just described, is this classical description of Kaposi sarcoma, or for step 1, usually we ask different description?
I don't know what exactly they'll ask in step 1. I think is a key pointer, but like I said before, the most important um, marker, I think that was the most important thing here was the HHV8 staining. Yeah.
Okay, well, for step 1, actually asking that you should remember that Kaposi sarcomas. Can you mute your microphone?
Okay, sorry.
So for step 1, usually what is asked is to remember that a Kaposi sarcoma consists of the spindle cells. Tumor consists of spindle cells, so with large vascular spaces and with lots of red blood cells or erythrocytes within the tumor. So that's what classical description. And indeed, for step 1, you need to know these things. And lack of the knowledge how it's described in step 1, it's kind of will be big minus if you will be taking step 1 exam, guys. So please review histological description of Kaposi sarcoma. Just open first aid book and just search Kaposi sarcoma. Find the article or first open a firecracker. So it also was given in my lectures when in GI tract we had Kaposi sarcoma. Very good. And last question goes from group number 4. How does candidiasis present? Joshua Babwale asked. So who would like to answer this question from your team? It's the last question for your team. Well,
East.
So how does candidiasis present?
White plaque.
So candidiasis present with white plaques. All right, where?
The tongue.
All right, that's all?
Mouse.
Oh, all right, so any other suggestions from the team?
You have white plaques on the mouth. You also have odynophagia.
And odynophagia, absolutely right. What usually histologically, or let's say, what kind of findings we will see if we take a biopsy of candidiasis lesions?
Pseudohyphae.
Pseudohyphae, very good. Excellent. All right. Thank you very much. So